Okay, today is the 11th of July, and I'm here with Dr. McCormick. And the reason for this call, so let me tell you how this came about. I was doing some discovery calls for a program that I'm running. And what I heard over and over again is women saying, I think about my bones all the time. And I thought, I wonder if that's a good thing. And I then asked Dr. McCormick, do you think about your bones all the time? He's like, never. And I thought, okay, well, there's a man's point of view, perhaps. But Dr. McCormick's story is one that's, to me, fascinating, and how we got here. So when I thought about people are thinking about their bones all the time versus being on this journey, understanding that it's a journey, it's a long journey. Our bones didn't just sort of crumble overnight. I don't mean to crumble, but get weak overnight. It came with time and stress and challenges. So I thought that if we break down some of the case studies, you'll hear the whole process. And one of my biggest concerns is that people will go and get their DEXA tests. They'll go to an endocrinologist. The endocrinologist will look at the tests and say, okay, I have your DEXA, here's your script. And there's an ocean of conversation in between that. And so that's what I wanted to highlight tonight. So some of you know me, some of you don't. I'm going to do a little introduction. So I'm a integrative health coach and patient navigator. I specialize in bone health and offering 12 years of focused experience. I provide evidence-based education and personalized guidance for your bone journey. I find bone doctors, DEXA with trabecular bone scores, and I'm by your side all the way throughout your journey. So drawing on my own personal triumph of osteopenia in my 50s to strong bones in my 70s, I'm equipped to guide and support you. So that's me. And Dr. McCormick, do you want to say anything about you, or do you want me to brag about you?
You can introduce it.
Dr. McCormick, his story is one that needs to be heard, I think, over and over again. In his 40s, I'm not going to say exact numbers because you had a negative 4.3 or a negative 4.5. Either you were 45 or 43. So I get those numbers. But anyway, it was severe. And you were fracturing. You had 12 fractures over a very short period of time. I think it was five years. And then as time progressed, you continued to fracture, because you told me at one point that you had a total of 22 fractures. Wow. Yeah, that's true. True story. So he wrote his first book, The Whole Body Approach to Osteoporosis. No, I'm shortchanging that. He went on a very, very long journey because he didn't fit the protocol. He was a man. He didn't go through menopause, and nobody, I think, knew what to do with you. Yeah, is that?
Well, I met up with this great endocrinologist at University of Connecticut, and Dr. Royce. He's since passed away, but he was really super. And I think he didn't really know what to do with me, but he was so, had no ego. And so he really let me kind of call the shots. And he said, Keith, whatever you want to do to track this down, let's do it together. And which was just really super. And, so it led me on this really stressful but kind of fun path of figuring this thing out. And with that, I think I grew and I learned a lot. And so, yeah, it was
It's almost like that doctor that brought you through the journey is what you're doing now, right? You're taking people through the journey.
I mean, he was definitely focused on drugs, and he really did not know about nutrition, I mean, at all. So in that respect, no. But the nice thing about him was he was on my team, on my bench, no matter what. And I thought that was cool for a medical doctor to put aside his ego and just say, I don't really know what's going on here, but let's go with this and try to figure it out. And I do the same with patients too. I don't say that, hey, do this or do that. I say, this is kind of what I think's going on, and this is a really good plan to do. But this is you call the shots, and a patient should call the shots. They should listen to professionals and kind of make their own decisions. And I try to do that with patients too.
So before we go into my translating what Dr. McCormick just said, because there's a lot there, over the last, 13 days, that you did a half Ironman, a 10K, and then did a marathon to qualify for the Boston Marathon. And you're 69 years old and you don't think about your bones, but still have osteoporosis and you don't think about your bones. So what I want to
that's because the number osteoporosis is just a number. And also remember, bone density is just bone density. It doesn't have to do with bone quality. So you got to mix the two. And I was way, a long time ago, at a negative 4.5. So I'm way better than that. And I'm, pretty sure my quality is way better than that. And my laboratory tests are way better than they used to be. So that's why I don't think of it. And it's, yeah.
So you sort of touch base and do maybe a CTX or P1NP from time to time.
A while.
Yeah. So when Dr. McCormick advocates with a patient, he'll take the whole case study and then say, here's my recommendation, whether or not it's to go with medication or not. And if it's to go with medication, it's which one you would recommend. And then the patient will then go to their endocrinologist or the primary care physician and get the medicine. And then hopefully, this is the one thing that I found from your book, which was so important, come back and work with you over time, because it does take time. And that's where, is that a fair assessment?
Yeah, it's a long-term project. And so, we get things rolling, but then every 6 months or a year, we have to touch base and do more lab tests, see if the person's doing, going in the right direction. But yeah, it's not a
quick fix.
It's not a quick fix. And it's not like, going in to see some endocrinologist, like you said, and they just prescribe a drug and you're out the door. And it's not that way.
No. So we're going to go over Emma's case. Emma's case is on page 75 for those that have their book, which is, whoopsie, the Great Bones book, which is a great book. It's a great bones and it's a great book. I'm going to tell that fast story. So when I was doing an intake, a potential client of mine said, they don't listen to me. They just don't listen. Doctors don't listen. I said, I ended. No, they really don't listen. I was talking to my one doctor and I said, he says, you need medicine. I said, I don't know if I need medicine yet. Wait, not so fast. And she said, no, you need, no. So she said, the patient said, you should read this book, Great Bones by Dr. McCormick, Dr. Keith McCormick. Okay. The doctor said, okay. And wrote in her portal, Dr. McCormick says patient has great bones. This is, it's absurd and it does happen. And, we have to be educated to have that conversation from a place of knowing. And I think that that's the very important part about reading his book and working with Dr. McCormick. Okay. So you want to start with Emma. Emma was, this is the way you open up a lot of case studies, that she broke down in tears because she was so caught off guard. This is what I hear all the time. I don't know how this happened to me. I eat well. I exercise really well. I've been exercising all my life. How could this be? So this is a phenomenon, and we just have to try to get to the root cause and see if the bone loss is continuing. So Emma was that person. She came into your office and she broke down in tears and couldn't believe her DEXA report. She had severe osteoporosis with a 22% risk of sustaining a major fracture in 10 years. And that's based on the FRAX. That's the correct assessment that you had that number. So what do you want to tell us more about Emma?
Let's just look at that third paragraph and see all the things that are big flags. Like, she's 57-year-old and 7 years past postmenopause. So, right then she has just gone through 7 years probably of bone loss at a higher rate, because for 5 to 7 years after menopause, that rate of bone loss probably at least doubles from what it was, before menopause, or triples sometimes. That it really increases. So just that, you go, oh man, 7 years past menopause, that's a big deal, and her menopause was difficult. What's that say? It means that she really had probably a drastic loss of estrogen, and that her adrenal glands and the fat within her did not was not capable of producing the estrogen that she needed. So the ovaries give out, and then the adrenal glands and the fat cells have to produce a little bit of estrogen to keep some estrogen in the body. And if the adrenals and the fat cells are not there, and many my patients are a little too thin, so they have less fat cells, they are not capable of producing that estrogen. And so they go from 100 picograms per ml of estrogen, of estradiol, to 0. So it's dramatic. And when that happens, a lot of times then they have a much more difficult time with menopause. So another big red flag that, that says bone loss.
So how do you know about the fat cells? Is that a visual thing where you look at the weight? You ask about weight?
The weight, if a person comes in and they're 5'4" and they're 105 pounds, that's a problem.
Do you find that a lot of your clients, and not because I'm finding all over the page that some are petite in weight, 100, 105 below. Do you find that to be the case?
Yes. Men, I think one of the biggest things I see with rapid bone loss is weight loss. So if you are low weight, or if you go from 120 down to 105 because of some reason you got sick, or COVID, or whatever, whatever thing, have stress or something like that, that's a real big sign that there's probably some bone loss there.
But it's not necessarily always the case. I mean, there are women that are bigger women who have osteoporosis.
That's true. Yes. Yeah, most definitely. But the numbers are greater for lower weight.
Right. It's so interesting because we were all concerned about being so thin as we're going through life. Twiggy. But anyway, okay, go ahead. So she had hot flashes, severe hot flashes, you were saying, and that was
after her third child. And what I didn't say was she breastfed, which is great, but it also takes calcium, and a woman's bone density does decrease when she breastfeeds. She typically gains it back if everything's okay, but if they're not healthy, then they don't gain it all back oftentimes. So there's another little bit of red flag saying, she had 3 children, breastfed, okay. At the fourth one, she's hypothyroid. And as you read further, she was given too much medication, and her TSH dropped down below 0.5. So when TSH goes below that, then because they've been given too much thyroid medication, then that can increase bone loss. You need TSH to stimulate the osteoblasts to form bone. And so it's not only that excessive amount of thyroid medication can ramp up osteoclastic activity, but the lack of TSH decreases the ability for osteoblasts to form bone.
Okay, so for the people on the call that don't know some terminology, osteoclast is the cell that clears away, and the osteoblast is the cell that builds the bone. So if you have any questions about some terminology, put it in the chat, and then we'll check it out. And you do a full panel when you look at when you look at the thyroid. Do you?
I'm not a thyroid person. I don't know a lot about thyroid issues. I like to look at the full panel, but I'm really focusing mostly on that TSH.
Okay.
For what I do.
And then you discovered that she had some bloating after meals and episodes.
Now we have a GI issue, and why is a GI issue a big deal? Not only because you're not digesting well and probably not then absorbing nutrients as well, but also 70% of a person's immune system is within their gut. And anytime you have an inflammatory issue, an irritation issue in that gut, you're going to ramp up what's called pro-inflammatory cytokines, and you're going to possibly get leaky gut issues, and all that stirs up a background of inflammation in the person, and that background of inflammation then stimulates the osteoclasts to break down bone, because the osteoclasts are a form of a white blood cell, and so they listen to the signals, the molecular signals from the immune system. And any immunological cells, the white blood cells, they talk to each other, via interleukin-1, interleukin-6, tumor necrosis factor, interleukin-17. All these are pro-inflammatory cytokines that the white blood cells talk to each other with, and all those stimulate the osteoclast to break down bone.
So what blood test do you use to get that data?
Well, I mean, I just look at a person's gut health and see, I mean, I can do like a GI map. That's by Diagnostic Solutions to see if they have overgrowth. You can look at enzymes to see if they're producing enough enzymes in their gut to digest things. You can see if they have fat buildup or increase in fat in their stool, which says they're not digesting well.
No, if there's fat in the stool, does it float? Is there like a greasy?
That's a good thing. Sometimes we can see a greasy film in the water, or the stool floats. It shouldn't float, it should sink. And if there's fat in it, you're not digesting fat. And why do we care about digesting fat? Well, number one, nutrition, but number two, what's vitamin D? What's vitamin K? What's vitamin E? Those are fat soluble vitamins. So if you're not digesting fat, you're not going to absorb those nutrients as well.
Point. And what happens if there's white in the stool? Do you ever come across white?
White. Well, I mean, if you're talking gray, you're talking white. White. I don't know. Gray, a lot of times they are like a bile salts, and you're not digesting well. But I'm not sure about white.
All right, I didn't mean to get you off tracks. All right, so Emma comes in with, she's unbelievably depressed because of her exam. She's had 3 children. She's gone through, she has a thyroid issue. She's not digesting.
And she's low weight, 113 pounds.
Low weight.
Even though she looks good, she wasn't good underneath.
Well, that's the interesting thing about that whole visual, right? You look good, but what's underneath?
Well, a lot of people look good. I mean, I think when I was 45, I looked okay. I was strong. I was doing races and stuff. Obviously, I wasn't okay. So.
Well, that's a really good point. Because you look fabulous. I love your hair. Okay. But she exercised regularly and did not sustain bone fractures. And that was an important piece to know as far as the intake, right? There was no previous fractures.
Right. So then I did some lab tests, and you can see all the lab tests there on page 76. I won't go through them. Well, okay, let's go through some of them. Her bone density was -3.3 in her spine, -3.0 in her left hip neck, and left hip total was -2.8. So not great, not terrible, but not great. When I see something like that, what perks up when I see that? What perks up is that -3.0 in the left hip neck. And the reason why is because I see spines as, well, we can fix that pretty easy. You know, spine bone density is much easier to improve upon than a hip. But when I see -3 or worse in the hip, then I think, wow, that's not good. We have a long struggle ahead of us. And because the hip is more cortical bone than the spine is. The spine is more trabecular bone, and cortical bone doesn't turn over as much. And if it doesn't turn over as much, you can't improve it as much.
So this is an important point as far as the hips. The hips is what Dr. McCormick's saying is that that's more difficult to improve through nutrition, through supplements, through exercise.
And drugs. It's hard. Prolia actually does a pretty good job on improving hip, but even like Forteo and Tymlos, those anabolics, not great. The oral bisphosphonates, not great. Fosamax and Actina, reclass a little bit, but remember, reclass, you're not going to get any bone quality. So that's where when I see somebody with a -3.3, 3.4, 3.5 in their hip, that's probably when I'll say, you probably should do Prolia, even though I don't like Prolia for a lot of reasons, but that's why I'll pick Prolia over something else.
So let's just dive into that for a second. So you don't really like Prolia. Why?
Well, mainly because of the transitioning off of it and the rebound effect from it. I mean, there are issues with infection issues, but I don't see that a lot. But it does affect the immune system. And I think it's pretty well tolerated. So mainly because of the rebound. And I think what what people don't realize is the longer you're on Prolia, the harder, the more chance you're going to have a rebound, and the less likely you're going to have of preventing that rebound. So, do I have time to talk 3 minutes about osteomorphs?
Yeah, but before we go there, so when Dr. McCormick says rebound, it goes back to where it was, if not, right? It goes back. You lose everything that you gained if you don't have a next step after Prolia.
And the reason for that rebound is this, and I love to tell the story because it's fascinating. And I talk about it in the book, so you can reread about it in the book. But Prolia is an antibody against sclerostin, and I mean against rankle, RANKL, so it's receptor activated for nuclear factor kappa B. So that's just it's just a molecule that stimulates the osteoclast to break down bone. So, but it's an antibody against rankle. When you stop Prolia, so Prolia lasts for about 6 months. When you stop, it stops. I mean, it really just stops. Like within 2 weeks, its effect on you just stops. That's not like a bisphosphonate. Bisphosphonates, you stop that, and it keeps working for up to years afterwards. But
Years? Like how many years?
It depends on how long you've been on it. If you've been on Fosamax for 1 year, it really only keeps that CTX down for another 6 months or so. Then it really starts climbing up. But if you'd been on Reclass for 5 years, that CTX is going to stay down for quite a long time. It'll stay down for 2, maybe 3 years, and then it starts slowly creeping up. So it depends on how long they've been on a drug and what drug it is. Okay, back to the Prolia. What happens is it doesn't kill off the osteoclast. What happens is the osteoclasts shrivel up, they shrink up, and they become in a state of suspended animation. They don't die, but they're there, but they're a little shrunken up. And then they coalesce into these islands of little what's called osteomorphs. The osteoclasts turn into these osteomorphs. They coalesce into these islands of 10, 20, 30 osteomorphs. And the longer you're on Prolia, the more these islands you have throughout your system.
Well,
so you get more and more and more of these osteomorphs. 3 years, 4 years, 5 years, more and more and more. Okay, now the person stops Prolia. All these osteomorphs plump up, burst out, break away from these islands, and you are just inundated with osteoclasts that then start breaking down bone. It's a little scary to think about that. And that's why backing it up with Reclass sometimes doesn't work, because you have all these osteomorphs that the Reclass just can't do it. But for sure, you don't take Fosamax or Actonel. They're just not powerful enough. But the Reclass will stop that rebound, especially at 1.5 years or 2 years of Prolia. So 3 or 4 or even 5, 6 maybe injections of Prolia. But boy, you start getting to 4 or 5 years, 6 years, 7 years of Prolia, it's sometimes very difficult to stop that rebound. And then a person loses a lot of what they gained. And it's not just that they lose the bone density that they gained, but that rapid loss of bone density causes a rapid loss of quality. And so it's logarithmically worse to their bones. And so their fracture risk increases more than what you would think it does for the loss of bone density that you see.
Ooh, okay. So that was a really important point. And now we slipped into
Now back to the case.
Yeah, but I wanted to ask you about Avinity for hips. How was that?
That's a really good question. Avenity's been out for 4 years. So Avenity is an antibody against sclerostin. Sclerostin is a protein produced by the osteocytes, and so sclerostin, you don't want to have too little bone, you don't want to have too much bone. So too little bone is osteoporosis, osteopetrosis is too much bone. And so your body has a way to not have a person get osteopetrosis, and that is sclerostin. It prevents the osteoblast from making too much bone. So Evenity is an antibody against the sclerostin. So now we've taken away that stopgap of those osteoblasts. So the osteoblasts can go hog wild and make tons, of bone. And it does a great job. And where's it going to do the great job? At the place, at the spine, because that's where the bone turnover is. That's where the trabecular bone is. Remember, in the cortical bone, there's not a lot of bone turnover. So none of the drugs help, and including Evenity, help the hips as much as they're going to help the spine. And I've had only, because it's only been out for 4 years or so, I don't think I've had more than 20 patients on Evenity. And I just had one today, and she just finished, and she only improved her hip. I think it went from like, I can't remember, but it was like 2.2. So it was like her hip neck went from negative 3.5 to negative 3.3 or something like not even statistically significant. And I was really, really disappointed. And her spine went from, I can't remember the numbers, so I'm just going to make them up. There was like negative 4.0 to negative 3.1. There was I think it was a 0.9 improvement after 1 year, but the hip, minimal. So that's not what the literature says. The literature says that the Evenity will improve the hip at, I think, 6% and the spine at about 12%. So, but what I'm seeing is not quite that good. But I have only limited experience with it. So.
Okay, so let's get back to Emma. So,
all right, okay. Let's go through. We'll go through some of her labs, so I can tell you what I was thinking whenever I saw these labs. So on page 76, estrogen level less than 5. Notice how it went up to 8 picograms per ml. Why is that? We didn't give her a drug. We didn't give her, estrogen, but she was getting healthier, and that getting healthier allowed her then to produce a little bit more estrogen, which was great, because what's estrogen going to do? It's going to help bring that CTX down. So it's going to help calm. Estrogen is an immune system modulator. It takes those osteoclasts and calms them down, so they break down less bone. So when I saw her go up from less than 5 picograms to 8 picograms, I was ecstatic. I just thought that was hot stuff, Okay.
Red blood.
Red blood cell count. Yeah, even that increased. So why is that significant? So when I see someone with low red blood cell count and a really low bone density, it's often, it can be just anemia for sure, but it's often because their bone marrow is filling up with fat that crowds out the red blood cells, the hematopoietic stem cells that produce red blood cells. And so a person has less red blood cell count because there's fat in their bone marrow. So the fat not only crowds out the hematopoietic stem cells, but the fat also releases palmitic acid. And palmitic acid is poisonous to the osteoblasts. So the osteoblasts they're less capable of producing bone. So watch what happens when she improves a little bit in her red blood cell. You go down a few takes, and well, you can't really see it because her P1NP, and this is a hard thing to talk about, to explain, but look at the lower two. This is the kind of thing that I love. I'm so glad that you had me do this, because this is the kind of stuff I can't explain in a book. It would take me forever to explain it in a book. So look at the last 2 lines, and I see CTX and P1NP. Look at
let's explain those. Let's explain those.
CTX is C-telopeptide. It's a measure of bone collagen in the blood. So it's a measure of osteoclastic activity. So when the osteoclasts break down bone, they eat it up, they spit out the collagen, and then we measure that collagen, and we say, oh, geez, look at that. There's a lot of collagen. There must be a lot of osteoclastic activity. So this is not cut in stone, but what I see in patients is if they are 350 or less, they're probably not losing bone. If they're 350 or 400 or more, they're probably losing bone. Now,
So let me just interrupt for a second. So that is an indicator. If one is on medication, you want to have that as a baseline before that, and that
always get a baseline. Yeah.
always get a baseline if you're doing medication, but also if you're tracking from a nutrition point of view and you're changing your lifestyle and your eating and whatever. So
And let me say one thing, because this is really important too. I had this patient today, and she just started, or she's going to start Evenity this week or next week. Due to factors of stupid insurance issues, we couldn't, because she just was a new patient today. So she can't get a P1, her doctor didn't order a P1NP. So we're not going to get a baseline P1NP on her, even though she's doing Evenity. But what I wanted to say was, when you're doing an anabolic drug, Forteo, Tymlos, or Evenity, it's the P1NP that we have to look at as a baseline and 3 months later, because the P1NP, I didn't explain that P1NP is called procollagen type 1 N-terminal propeptide. And what it is, it's a measure of osteoblastic activity. It's a blood test, measure of osteoblastic activity. So if you're doing anabolic drug, you're stimulating the osteoblasts to form bone. So it's the P1NP that you want to look at before you start and after 3 months into it. It's the CTX that you want to look at if you're doing an anti-resorptive drug. Why is that? Because the anti-resorptive drugs, Prolia and the bisphosphonates, they are making the osteoclasts sick, so they're decreasing resorption. So the CTX is a measure of osteoclastic activity. So we want to be looking at the CTX. So to recap, if you're taking an anti-resorptive drug, bisphosphonate or Prolia, you make sure that you get a baseline CTX. 3 months into it, you get another CTX to make sure it's working. It should be less. If you're doing an anabolic drug, Forteo, Tymlos, or Evenity, that's an anabolic, so it's stimulating the osteoblasts. So you need to get a P1NP beforehand, baseline. 3 months into the drug, you do another P1NP, it should be increased. Okay, so
I want to say something about that, because not all endocrinologists or primary care physicians will do those bone markers.
Including the patient today. They didn't do the P1NP. He did it, the endocrinologist did a CTX, but he was giving her Evenity. You got to do the P1NP too.
So that's why one of the key things about working with you, even though they have to go away, you can't prescribe, they have to go away for their doctor. Excuse me, they have to find a doctor that will.
I can order the lab tests.
Right, but I mean, yeah, but that's the point that I want to make, is that if the doctor will say, no, I don't believe in these bone markers because patients aren't compliant, they don't do them the right time of the day, they don't know how to do them. If that's the case, then say, okay, Dr. McCormick, will you order me these tests? And then you have a baseline. And so it's not like secretly working at a partnership, but it's like my bones, my body. I want to test this out.
And we all have different, quote, belief systems. I happen to believe that that bone turnover markers are important, and they are good to use. They're not. Are they perfect? No. Is the bone density perfect? No. There's plenty of people who have gone into their cardiologist and given a clean bill of health, and the next day they have a heart attack. So none of these things are foolproof. But the better you follow the guidelines to doing these tests properly, the more chance that you have of getting good results from it, and consistent results from it.
So let's ask a good question as far as Emma's case study, estrogen level going from less than 5 to 8.
So that's
how did she get healthier via food supplements?
Yeah, right. I mean, we put her on all. I mean, she really just completely changed her diet. She was eating, poor protein. We really switched everything. I think did we get her off of gluten? I can't remember if we did. Yeah, she had lactose intolerance, but I think she knew that before. I can't remember. But yeah, just improving her diet and making sure protein intake was good. Oh, we decreased her homocysteine. her homocysteine was a 14.9, so that's an inflammatory marker. Just that's going to help. Her C-reactive protein got improved. I think we gave her like quercetin and resveratrol, alpha lipoic acid. She did some supplements like that, which are all anti-inflammatory. So
what's your homocysteine target? 8?
That's a super question, and I can't tell you anymore because there's so many reference ranges out there. You know, I used to just think, well, you know, let's get it below 10, but now I'm seeing reference ranges of 0 to 17, and I'm thinking, is that lab? No, because a lot of times I see 0 to 12, 0 to 15, 0 to 17. So I guess is a general statement. If it's a 12, I don't get that excited, but I want to get it below 10. But sure, if it's a 15, 16, 17, then I get excited and I say, okay, that has to come down.
Okay. But
it's always easy to bring that down. So.
Emma eventually went on drugs, right? She went on.
Yeah, she did because, yeah, we just needed to get her protected. So she was.
Was it because she was young?
And she was young. She was only, she was 57 or something. So I thought, you know, she's going to live another 40 years. I don't want her to be worrying about negative 3.0 and 3.3 forever. You know, let's just get a little bit of bone density in her. And then, you know, and then we'll keep that CTX low and she'll be okay. So it just got her out of the hole a little bit, you know.
So she was on medication for 2.5 years.
I think she was on Fosamax.
Okay.
If I remember. I can't remember. But I think Fosamax, which was great, you know, it helped and it didn't hurt her. And then she was off and then she didn't have to go back on it. So can I talk about the CTX and P1 and P again? Yeah. Okay, so the bottom 2 lines, so everybody knows what the CTX and P1 and P are. I want to say this, and this also isn't cut in stone, and this isn't in the literature, it's just what I observed. But I like to see a ratio of 10:1 to 9.5:1 on the CTX and P1NP. So
is that new?
Yes,
it
is. I write down all these scores of all my patients, and so I'm trying to come up with kind of a ratio, and that's not cut in stone, you know, but it's kind of what I see is a kind of good ratio. So if a person has a 600, so she is a 623, I would have liked that to be, you know, a 50 to 60 on a P1NP. So the osteoclast and the osteoblast talk to each other. If a CTX goes high, the P1NP will follow it. It will go up higher. If a person has a fracture, the CTX goes high, the P1NP goes high. Why is that? Because all of bone turnover is happening. All of bone turnover is increasing. If the CTX go low, that's the osteoclast. The osteoclast and osteoblast talk to each other, so the P1NP will go lower. And you can see that reflected in this. So 6 months after treatment, her CTX went down to 380, but so too did the osteoblast, the P1NP. But look at the difference. It went from 48 to 41. Big whoop. Not a big deal. It was a drop, but not a big deal. If that would have been a drug that she was on, you know, a hardcore drug like Reclass or something like that to really drop it, that P1NP would have gone down a lot more. We want to get that. We want to get the CTX down, but we don't want to affect the P1NP drastically. And that's why we try to do things with nutrition, because even with nutrition and just not doing a drug, if the CTX comes down, the P1NP will come down, but not nearly to the same extent as it would with a drug.
So you're talking at roughly a 10 to 12%? Is that what your ratio is?
10 to, well, I'd say 10:1 versus, or 9:1, 9.5:1. So, so if you look at that 338 that she went to, 380, and then her P1NP went to 41, that's a good ratio. That's a way better ratio than the first one. Right. The CTX was too high and the P1NP wasn't high enough. But a lot of that, I think, has to do with that estrogen coming up. That's all I want. That's why that was a big, long story from the estrogen to those, but I wanted to say that. But,
Okay.
and I know I'm getting too deep for a lot of people, but I just want to say, this is just one case, and how much has gone into this. And as you said, that endocrinologist was out of that room 40 minutes ago, and after they just prescribed the drug and didn't do any of this stuff, or look at this with this, with this viewpoint.
So it was about a 2.5-year relationship that you had with Emma, with her
Oh, I
bone?
still see her, I think.
Still see her. Okay,
Yeah.
that's good.
No, it's, I mean, she's only what, I don't know, she's actually probably 65 now. But yeah, I mean, we still got to work on it,
Yeah, but how is she mentally? Why? I mean, is she okay with going through this? It's not like, oh my
Yeah.
God. Seriously?
Yeah, because, the bone density is better, and CTX is down. So we know that she's not losing anymore.
Yeah.
And it's okay to have the spine at 2.5 and hip at 2.7 if she's not losing, if that CTX stays down. CTX is not only an indicator of ongoing bone loss, but it's an indicator of fracture risk too. So a high CTX puts somebody at high risk for fracture.
Have you done a comparison, or have you tracked how many of your patients fracture?
No.
Okay. So do you want to go to Jen? Or am I
Okay.
good? We
What's
have,
that? Hey.
yeah, 107. We only have 15 minutes left.
Oh, I told you, and you want to do 4.
You're right.
Okay, go ahead. You do it.
Well, the thing about Jen, she's 55, young, postmenopausal marine biologist. She's 5'6", 140. A history of depression and SSRI medication for more than 20 years. So that comes up a lot, right? Because the whole antidepressant, the impact of SSRIs on bones. One of the things that people are not aware of is that, and I just want to say this, I went to my pharmacist yesterday and I said to him, you really are sitting on some important data. And he's like, what do you mean? And I said, because people can come to you to fill a script and then ask, what will this medication, what impact will I have on my bones? And that's a very important question to ask your pharmacist if you're on any kind of medication. So,
There's a lot of medications that adversely affect bones. So yes, you should ask for sure.
Okay. So she had chronic constipation. Does that come up a lot for you?
Yep.
So that means gut issues, right? She diagnosed with spinal compression fracture at L4, 3 months before visiting your office.
See the one that was in the boat, I think?
With the boat, right? She was a boat lady. She was thrown violently in the air.
Biologist down in Woods Hole. And yeah, go ahead. I'm sorry, didn't mean to.
And she landed on her buttocks and she felt this severe pain. The x-ray showed a 75% compression fraction of the L4 vertebrae. Jen told me that she had seen an endocrinologist 2.5 years before the fracture because her DEXA exam had indicated severe osteoporosis. Her T-score at that time was a total of 2.9 and negative 3.0 in the hip. And the doctor gave her a 2-year course of terapeptide, which is Forteo, which is
and this is your next sentence is what really upset me, because she didn't follow it up with the drug.
So now 2 years later, so she didn't lock in the gain.
Yeah, well, 2 things. She didn't gain, and no P1NP was done. So we would have known that she wasn't gaining if we would have done a baseline P1NP and a P1NP 3 months into it. But also, then after she stopped after 2 years, she wasn't given an anti-resorptive to stop the rebound. There's a rebound from Forteo and Tymlos also, just like not as drastic as Prolia, but there is a rebound. If you don't follow up Forteo or Tymlos, those anabolics, with an anti-resorptive, then you'll lose a lot of the bone density that they gained. And she wasn't given a anti-resorptive.
So the sequencing of medication is important, and a follow-up to an anabolic is always part of the protocol.
After.
Have
And
to.
I have no idea, why, and she didn't know why. And the other thing was, that her MD said, I don't know if it was a GP or endocrinologist, I forget, but just said, "Oh, she's holding steady," and she wasn't holding steady. I didn't understand that, but he said that several times to her, that no, she's fine, she's doing good, and it wasn't true. So,
But in reality, the Forteo didn't work for her.
and it didn't work. Yeah, right.
So that's the issue about taking the P1NP or the CTX while you're on a course of medication. So you see if it's working. What is an SSRI? Serotonin, can you break that down?
The
Yes.
serotonin it's a reuptake inhibitor, and so what happens is the levels of serotonin in your body change, and there's brain serotonin and there's gut serotonin, and they kind of do a little bit different things, but in the end result is, if you decrease the ability to have it reuptake, then it stimulates those osteoclasts to break down bone. So, and it's not as dramatic as they used to think. And I'm not sure if it's because the SSRIs today are a little bit less of a problem than they used to be. I don't know, but I have a lot of patients on SSRIs, and I guess what I feel like is it's a huge part of their health to take these, and their comfort and their their emotional health. So yeah, I'd like them to get off, but a lot of times they can't get off, and so sometimes that's better than it's okay sometimes. It's not great, but I think it's not as bad as we thought it was initially.
But it's an important piece of data when you're.
Yeah, it is. Yeah.
Right. And Barbara Smoller was asking, do they contribute to decrease in bone density?
Yes. But not as much, not as drastic as I think the initial reports said.
So all these little pieces that contribute to bone loss is something that Dr. McCormick will look at and say, okay, we got this that's showing bone loss, or that's supporting bone loss, and we're not eating right, and the gut health, and all these little pieces that often go ignored when you just, here's your DEXA, here's your script. And I can't say that enough because it's so deep. The work is so deep. Okay, but I had one question here. Wes was asking, anabolic meds, do you totally rebuild your bones in the first 6 to 12 months and therefore need to be more careful with exercise?
More careful with what?
Exercise?
I guess I didn't quite understand the question, but they don't totally rebuild. So can you say the question?
On anabolic meds, do you totally rebuild your bones in the first 6 to 12 months?
Is that asking whether you totally rebuild it to normal, or you build it as much as it's going to build? It doesn't work any more after that. So I guess I'm not clear on that, but I'm going to just say what I think. So 6 months, no, it's definitely not. So like Forteo and Tymlos, they just get up and running at about 3, 4, or 5 months. So the first 3, 4, 5 months, you're actually more at risk of fracture than you were before you started the drug, because they've jacked up osteoblastic and osteoclastic activity. When you get to about 6 months, then you're starting to get protection from the drug. And they work pretty good up to about 18 months. They're building bone, and then they start petering out a little bit. Some people at 18 months are still going strong. And how do I know that? I know that because the P1NP is still very good. At 21 months, the P1NP is still very good. And at 24 months, the P1NP might still be showing that they're improving. But oftentimes at 24 months, you stop it because that P1NP starts going down. So that's way longer than the 6 to 12 months. Evenity is about the first 8 months is anabolic, and then the last 4 months it's anti-resorptive. So So on that, you're improving bone density from actually bone tissue for the first 8 months. Then after that, it's more you're improving bone more from a increase in density more than the actual tissue itself.
So Barbara, who I know, said that there is Columbia University Medical Center is currently doing a study on depression and SSRIs on bone density. So more information will be forthcoming.
SSRIs, what bone density?
They're doing a study on depression and or SSRIs on bone density at Columbia Medical. They're doing a study. So what do? We're out of time. Let's finish, Jen. Is there anything in particular that you want to highlight about Jen?
Just the fact that I think the biggest takeaway from this is that you have to do a follow-up drug when you do an anabolic, and you need at least a 0.3 standard deviation improvement of the spine to say a statistically significant change, whether it be improvement or a loss. So if you get your bone density and it's a negative 3.3, and you work hard, and after 6 months or a year, it's a negative 3.1, you haven't lost necessarily, because, or if it's a negative 3.5, you haven't necessarily gained, because it's not, that's only a 0.2. So you have to have at least a 0.3 standard deviation difference to say, oh yeah, statistically significant change, that's an improvement or a loss. And with the hip neck, it's a 0.5 you have to get. So the hip neck is very squirrely to do right. The technician has to angle your hip just right. And if it's not done exactly right from scan to scan, which it often isn't, because it's two different technicians doing it, there's going to be a variation there. That's why it's a 0.5 on the hip neck. So I guess that's the biggest takeaway from that story. And
may I ask, or would you be willing to share your protocol for your medication for your osteoporosis?
For me?
You, Dr. McCormick. What did you do? What did you take?
Way back when. Okay, I did Forteo and for 2 years, and it really helped. So it went from negative 4.5 to, I don't know, I'm going to make this up because I can't remember, maybe a 3.7 or something. I don't know, because the end result, because then it took 6 months of Forteo, and then it went to 3.3. So
6 months of Fosamax.
Fosamax, sorry about that, Fosamax, and then it went to 3.3. So I don't really know, I can't remember what it was after Forteo itself, but anyhow, after 2 years of Forteo, 6 months of Fosamax, it was a 3.3. So, and that's where I've stayed for 20 years now, 25 years. I don't know how long it's been. I'm 69.
You got to stop running. Okay, so we're out of time. Vicki, was there anything in particular that came out that you saw that needed to be shared?
You covered a lot of the questions. I do have some others I wrote down. Let's see. So one from is a patient of yours from Pittsburgh, Kathy. May I ask, is Fosamax an effective follow-up to 2 years of Tymlos? The endo nurse said must be reclassed or Prolia. No. I mentioned you did fine with that, and she said, oh, men are different.
No, that's not true.
Okay.
Well, men are different, but
no, they're not.
But no. And how are we going to know if that Fosamax works?
CTX.
Yeah.
That's right. So we know that hopefully she had a pre-therapy, pre-treatment baseline CTX. Hopefully after the, what was it, Tymlos or Forteo? I can't remember.
Oh, it was Timlos. It was Timlos.
After the Timlos was finished, we got another CTX, so we know what it is. And then, so hopefully it was, way up at 700, 800, something like that, because that's what the Timlos would do, or 1,000 maybe. And then you do Forteo, and if it brings it down to 250, 200, it's working. Now, if it didn't, if it's still up at 600, 3 or 4 months after you started the Fosamax, then for sure, yeah, go to reclass. But let the CTX do the talking, not guessing game.
Okay, I
Yes.
have one from Nancy who said, I completely agree with P1MP when on an anabolic, but my doctors prefer BSAP or osteocalcin instead of a P1MP. Would love your thoughts on the validity of these two other tests to measure osteoblastic activity when on an anabolic.
Well, osteocalcin is a really squirrely test. It's not very accurate. It's really affected a lot by time of day, by food, by just a lot of things. So I actually don't even get osteocalcin anymore. I used to 10, 15 years ago, but I don't anymore. The P1MP is a pretty darn rock solid test, way more than CTX, way more than, any of the others. So I disagree that osteocalcin isn't the way to go. And as far as bone-specific alkaline phosphatase, that's a good test to get if you're looking for oversuppression of osteoclastic activity with a anti-resorptive. BSAP is a good test for that. But if you're talking about actual knowing whether you're building bone, the P1MP is far superior than the BSAP.
Okay. Linda asked, what do you think of bioidentical hormones for 69-year-old woman?
Oh my goodness. Herman knows how I've struggled with that question.
Yeah.
But yeah, I think now I don't know. yeah. I'm coming around to that a little bit.
Yeah, it's been a big conversation, especially after the Natural Osteoporosis Summit 2.0 with Dr. Felicia Gersh, who says she's very much in favor of that. But it's a big conversation, and we'll see. We'll see. I mean, I sense that if you're under the guidance of somebody who really knows bioidentical hormones, does the tests you regularly to see where your estrogen and your levels are, and to see. I mean, you have to follow it up with tests.
And I wouldn't rely on that to build bone density. If you want to calm down those osteoclasts with it and you use a low dose estrogen, let's see if it works. 20, 30 picograms per ml, getting that estradiol up to. But if you're using it to decrease osteoclastic activity to the point where you're treating the osteoporosis, no, I don't think you should do that. If you're doing it for overall health and overall calming down of the osteoclast, in addition to an osteoporosis specific medication, if the person needs it, then that's okay. But don't use it if you need a medication because your bone density is so low. That's not the way to go. I don't think you need to do an osteoporosis specific medication.
So, Vicki, I'm just going to ask Dr. McCormick, because I thought that was a good question. How did you find out that he was gluten sensitive? Did you do a test or did you do the elimination diet? Yeah.
Oh, yeah. Well, that's a really cool question because, and it was a little bit of a bad point about my whole treatment because my doctor did an anti-tissue transglutaminase IgA on me.
Nobody knows how to pronounce that. What is it, the IgA? That you say that so fast, it's like one word, but it's 4 different words.
Tissue transglutaminase, IgA. So transglutaminase is just an enzyme produced by the endocytes within your gut. And when they burst, when those endocytes, the little villi in there get destroyed, they release transglutaminase. There's like 7 different transglutaminases in the body, but this specific transglutaminase is within the gut. And your body says, oh, that shouldn't be there. And I'm going to produce an antibody against it. And that's what anti-tissue transglutaminase, IgA, is. So if you're having if you have celiac disease and you have damage to those villi in the gut cells, that TTG, I would say TTG IgA is easier to say than anti-tissue. So that level will go high. But my TTG, the problem was number one, all they tested for me was TTG IgA, and it was a 19. Well, a 19, so 19 is negative, 20 is or higher is borderline positive, 25 or more is positive for celiac disease. Well, I was in 19, and nobody told me. And number one, I didn't know anything. This was 35 years ago or something like that, and so I didn't know the test then. Nobody said that it was a 19, and everybody said, "Oh yeah, you're not a gluten sensitive person." And but it was a 19. Well, it's like saying, pregnant or not pregnant. No, this is a continuum, and it probably could have been a 20 on any other day. So all I'm saying is, it was a year later before I found out that it was a 19. Before I actually looked at I started reading about gluten, I started reading about testing for it, and I said, I think he tested for that a year ago. I'm going to go back into my lab test and see. And I go, oh my God, it's a 19. I'm positive. I'm not celiac maybe, but I'm certainly sensitive. And at that point, I got my anti-gliadin antibodies, IgG and IgA, and they were 35 and 38 or something like that. So they weren't astronomical, but they were certainly high. You want the anti-gliadin antibodies to be, a 3 or less or something like that. But mine were 35, 38, something like that. So anyhow, so I am very sensitive to gluten, even though I eat, I can eat donuts out the wazoo and not have any sensitivity to them at all. Which
But do you eat donuts?
No, but I would like to.
What kind of glaze or the chocolate one? Only kidding. Oh, wait. So Dr. McCormick, you said something that I think is pretty key. You went back to your lab report. Keep your tests. Keep a file.
And when you go through your test, go to my book, look up homocysteine, look up CTX, look up red blood cell, look up mean platelet volume, because I talk about all those things in some chapter in the book, and then you can figure out, oh yeah, geez, that's a little bit borderline. What's that mean? Oh, my ferritin's a little low. What's that mean? Oh, what's that mean? And I talk about it in the book.
And I think I answered this question that yes, Dr. McCormick can order blood work. You can't order medication, but you can order blood work and various other tests and functional labs.
But I don't go through a person's insurance, so they have. Yeah,
it's out of pocket, and it's also at a reduced price.
Way reduced. Yeah.
Way crazy. Okay. Okay. So we have to end, and people are saying, let's do some more. Anyway.
That was fun.
Was it? It was fun for me too. So if you can just kindly comment on what was your takeaway from today. I mean, I know that's a big question, but it helps. It helps as we consider doing this again. Would you do it again?
Me?
Yeah. Sure. Totally. So what was your takeaway from today? That will be really, really helpful. And so Vicki, thank you very much for going through and culling through the questions. Is Forteo only approved for 2-year use?
Very much. And thank you, Irma.
Wait, before you go, is Forteo only approved for 2 years use from the FDA?
That's such a cool question too. So many cool questions. So before, a couple of years ago, there was a black box warning of 2 years, and then they rescinded that. So I actually had a patient on Forteo for 8 years, even when there was a black box warning on it for 2 years. And I don't know how that person got Forteo for 8 years. Number one, how their doctor kept prescribing it, or how an insurance company kept approving it, because that was, I had her as a patient like 5 years ago, and it was only the black box warning was only taken off a couple of years ago. But anyhow, so now you can take it longer, but there's no reason to, because usually its effectiveness starts wearing off and it just doesn't work as well. So
2 questions before we go. So Krista is asking, she had a DEXA test. She didn't have a TBS. She was just going into osteoporosis. Would you recommend her paying out of pocket and getting another DEXA test with a TBS?
Another good question. And I guess the reason why I use TBS is if a person has a negative 2.6, not a big deal. If they have a negative 5.0, I don't need to see their TBS. I know they have poor quality. But if they're kind of in the middle there, or if they have diabetes, like if you have diabetes and negative 3.3, I want to know what that quality is, because diabetes decreases the quality. But if you're right in that gray area of am I going to recommend medications or not, negative 3.1, 3.2, 3.3, 3.4. If we get a TBS, then, and it's a really poor quality, then yeah, you got to do a medication. But if it's a great quality and the negative 3.1, yeah, maybe not,
Mediterranean diet, positive? Yeah. What do you eat? What do you have for breakfast?
I could be a bullet, with a bullet blender. I can be a bullet blender salesperson.
Okay. What do you put in there?
Because I love my bullet blender. I go and I get these organic girl greens from Whole Foods, and it's like this plastic thing that's big. I actually take half of that. So it's only lasts me 2 servings, but I take half of those greens, put them in there. I put in a scoop of either amino acids, 15 grams of amino acids, or
Whose?
I'm sorry?
Whose amino acids? Yours?
No. I use Moss Nutritions. They have this thing called Amino Meal Select, which I really like. Vanilla, the chocolate doesn't taste good, but the vanilla tastes good. But
Amino, say it again. It's
Meal Select.
Meal Select, yeah.
Okay.
And then I have another that's MOSS Nutrition. And I don't mean to say this, but you really do need to have a practitioner's code to buy from them. And if you need it, mine's M079 is my practitioner's code to buy from them. And the other thing I use is Sarco Select. Once again, vanilla's good, the chocolate's not that great. And that's pea protein. So I take so either the amino meal or the Sarco Select, I put that in there. I take a big, heaping tablespoon of flaxseed. I sometimes put collagen in there. I sometimes put like
Do you grind the flax seeds?
Yeah.
Before the bullet?
No, I cheat and I buy my flax seeds done.
So they're rancid.
And I know put them in the freezer.
You do. Okay. All right, we got it. All right, so go ahead. I'm sorry. You flaxseed. Go ahead.
Maybe half of a carrot. What else do I do?
The protein powder that you use as a Sarco Select is the pea protein.
That's
right?
a pea.
And you put your collagen in there or no?
Yeah, sometimes. I mean, I think sometimes I probably shouldn't, because maybe it's just too much protein, too much amino acids in there. So, but sometimes I just throw it in anyhow. But I almost always usually have it in a soup or something late, like the collagen and something else. But sometimes I throw it in.
Do you drink coffee?
I'm sorry?
Do you drink coffee? Alcohol?
Never.
Smoke marijuana? I'm only kidding. And you take aspirin? Yeah. You're clean.
I don't do any of that stuff. Never have, never, ever, ever have any of that stuff. So.
Never had a drink?
Never had a drink. That's not true. I had this much of a beer once. So I'll tell you the story since. Yeah. So I used to be a farrier, shoeing horses. And I went to this ranch, and I do 5 horses that day, and I forgot my water. And I asked the farmer, this was down in Texas in San Antonio. And I asked the farmer if he had any water. He goes, no, but I got beer. And I was just so thirsty. And so he gave me this beer, and it was disgusting, but I was so thirsty. I drank about that much of it.
And that was it. Okay. You sleep well? Do you sleep well? Yeah or no?
I do.
Okay, enough with the personal questions. I'm sorry. Thank you for engaging me. Thank you, everybody, for coming and laughing with us together. I see some smiles on the panel, so thank you. We're going to say goodnight.
Good night, everybody. Thank you so much for joining. Bye-bye.
Thank you so much.
Thanks, Irma. Thanks, Dr. McCormick.
Bye-bye.
Bye.
Thank you.
Thank you.
Thank you.
Thank you so much.
Welcome. Thank you.